Good evening. I'm Tim DiTuro, and we are going to talk about antiarrhythmic medications. Antiarrhythmics are used to correct arrhythmias. Our objectives in this class, when by the time the student completes this course, they ought to be able to describe the different classes of antiarrhythmics. They need to explain the mechanism of action for each class of antiarrhythmics, recognize the indication for each class of antiarrhythmics, and then be able to communicate the side effects associated with these antiarrhythmics. It's important to understand how the heart works, to know how these antiarrhythmics work. Well, basically, we have the conduction system, okay, which is you've got the signal starts from the sinoatrial node to the atrium to the Purkinje fibers, through the AV junction to the Purkinje fibers, okay, and the heart also acts on or functions on what we call the sodium-potassium pump. And that'll be important as we start going through the different classes of antiarrhythmic medications. This is classroom learning, okay, and we will have a clinical part at the end of the course. We'll have 8 hours of clinicals to actually work with folks who are administering these medications. Let's begin with class 1 antiarrhythmic drugs. Now, these drugs act by blocking sodium channels. You got a class 1A antiarrhythmic, which is your procanamide, and it works on AV, junctional, and ventricular tachyarrhythmias. Then we have a class 1B antiarrhythmic drug, which is lidocaine, and we've all heard of lidocaine, and we've probably all used it. This is for ventricular arrhythmias. Now, this does have some adverse effects. Drowsiness, slurred speech, confusion, and convulsions. Then we have the class 2 antiarrhythmic drugs, and we know these as our beta blockers. They are B-adrenergic agonists. They decrease heart rate and contractility, thereby bringing the arrhythmia under control. And these are used for tachyarrhythmias caused by an increase in sympathetic stimulation, because it blocks those receptors. And it's also used for atrial flutter, and atrial fibrillation. Now, the most common of the class 2 antiarrhythmics is metoprolol. I know a lot of patients on metoprolol, and it seems to work pretty well. Then we have class 3 antiarrhythmic drugs, and they act by blocking potassium channels. Okay, is where your class 1 blocks sodium channels, class 3 blocks potassium channels, and they diminish the outward K current during repolarization of cardiac cells. One of the most common known is amiodarone. And another oral one that's been kind of popular, it's an older one, is called Sotalol or Betapace. Everybody studies about Sotalol and Betapace in school. There are other drugs that are used now, but that's one of the old trusted ones. Now, any class 3 antiarrhythmic is usually started in the hospital. You have to go into the hospital to start these because of the potential side effects of arrhythmias. These can cause QT elongation, and if the QT interval gets too long, it can cause VTAC. Okay, they have to monitor you for that. One of the most common side effects is bradycardia, or first-degree block. Now, dofetilide, I'm pretty sure I pronounce it, is used as a first-line agent in patients with persistent atrial fibrillation. And the reason I brought this particular one up, this particular medication is limited to use in the inpatient setting. Okay, you can only use it in the hospital. You can't prescribe it outside of the hospital because of the risks of proarrhythmia. Now, we have the class 4 antiarrhythmic drugs, and these are interesting. They block calcium channels. Okay, the most common, and we've all heard of them, is verapamil and ditlazam or cardiazem. These are quite commonly used in hospitals, especially cardiazem. We use a lot of cardiazem drips. Now, these are more effective against atrial than against ventricular arrhythmias. Okay, some common side effects include bradycardia, hypotension, and you also can get some peripheral edema. So we have to watch out for these things when we're using verapamil and cardiazem. And then we have one interesting one called adenosine, and I'm sure we've all used adenosine. It decreases conduction velocity. Okay, we basically use it for conversion of supraventricular tachycardia. Okay, it used to be known as a chemical cardioversion. It's got a half-life of 5 to 10 seconds, and it has to be pushed very quickly. Okay, and it kind of stops the heart for a second. You will get a little bit of asystole, and then in hopes that the heart starts back at a slower rate. We use this quite often in the ER. Now, we also have magnesium sulfate. And the interesting thing is magnesium is necessary for transport of sodium, potassium, and calcium. Okay, we've got to have magnesium to transport these other items. So it's given IV, and this is used to treat arrhythmias. The most common arrhythmia it's used to treat is torsades de pointes. Okay, we all know what VTAC looks like, and usually lidocaine or amiodarone is used in VTAC. Now, if that VTAC turns out to be torsades de pointes, then we need magnesium sulfate to convert it. So it's important to know which antiarrhythmic drug is going to best suit the patient that we are treating. And of course, we're going to, as far as our content for learning, we will cover these in class. Okay, we will have tests at the end. We will give case studies of these medications being used, and then every student will have 8 hours of clinical experience. Okay, and questions we may anticipate from the students. Questions like, can you give 2 at the same time? Can you be on a beta blocker and a class 3 antiarrhythmic? Okay, and that just depends on the cardiologist. Sometimes you have to block calcium, and you may have to block sodium channels. But the most important thing is, if we were giving a class 1 antiarrhythmic, okay, and it blocks sodium channels, what kind of blood work would we need to watch out for? Okay, so if sodium, that decreased amount of sodium getting used up by the sodium-potassium pump, chances are your blood levels of sodium are going to go up. Same thing with calcium. Okay, your blood levels of calcium will go up. And with class 3s, same thing with potassium. If you're using a potassium channel blocker, your blood levels of potassium will go up. But as I mentioned, those could be some common questions, and there might be questions about, are there reversals to these? Well, for example, if you give too much of a calcium channel blocker like verapamil, okay, and it blocks calcium channels, what would be the antidote to that? Okay, well, you would increase the calcium level in the blood to help counteract verapamil. So I hope this information is useful, and I'll list my references on the post. Thank you so much.